Anyone else?
Okay, so we had someone who very polite. She said, I didn't want to ask you this and embarrass you while you're on the video, Dr. Rutledge. But I am a medical professional. I'm a nurse. And I noticed that you're using this gabapentin. And I think the quote was that she shook her head and goes, what a blockhead. And so interestingly, this week they just published an article in our surgery journal called Obesity Surgery where they added gabapentin to the pre-op meds and they decreased the use of narcotics in post-op patients. Now, let me give you some background. So that just shows that we've been using it for 2 years and just shows how smart we are. Anyways, there's a whole area of research called opioid sparing or opioid sparing analgesia or anesthesia. And that gets back to the fact that going to sleep and waking up is serious business. There is a risk to surgery. The risks are the surgery itself, but the anesthesia carries risks. And the anesthesia risk goes way up the heavier you are. And it goes up even more when you have underlying lung disease like sleep apnea. Okay? Now, for the average patient who has surgery, usually there's cutting or bone setting or something like that, so there's the feeling of pain and the desire by the doctors and the nurses to control that pain, and the foundational drugs for the treatment of pain and anesthesia have been around for over 100 years. For anesthesia, it's gas anesthetics, and for pain relief or analgesia, it's narcotics. And those are really critical, fundamental, and actually extremely cheap and effective drugs. But both of those drugs have got big-time potential problems and dangers, particularly in a heavy person. For the gas anesthetics, which are wonderful drugs, they have two risks. One is 1 out of every 3 people will suffer from severe nausea and vomiting, postoperative nausea and vomiting. If you get gas anesthetics, 1 out of 3 of you would wake up retching, terribly uncomfortable with gas anesthetics. Uncomfortable, not particularly dangerous, but people who've had it say it's terrible. More importantly, the gas anesthetics, because they're fat soluble, dissolve in the fat and may come out unexpectedly in the post-operative period, causing respiratory depression, low oxygen, arrhythmia, and death. It's not very common, but you don't want any deaths if you can avoid it, and gas anesthetics can cause severe nausea and vomiting commonly, and occasionally respiratory depression and death, and so we don't like either one of those side effects. Narcotics are actually quite similar. Narcotics are wonderful because they relieve pain, but, and this should sound familiar, there are 2 side effects. Number 1, right, nausea and vomiting. Ever taken codeine? Retching, nausea, and vomiting. So depending on how much you need, how fast it's given, narcotics are very common causes of severe nausea and vomiting. Number 2, most importantly, just like the gas anesthetics, the narcotics can be deadly because they cause respiratory depression. So you want humanely to treat your patient with narcotics to relieve their pain, and as a side effect they start retching and vomiting, and in an obese, heavy patient who has lung disease, who's had abdominal surgery, you give them narcotics, all of a sudden they're not breathing, their oxygen declines, they have an irregular heartbeat, and you can have a death. So because of these concerns, for many years now, we've been using some of the latest new techniques in anesthesia and analgesia. For many years, we have eliminated, for over 10 years, we've eliminated gas anesthetics, and we use another kind of anesthesia called propofol. Are you familiar with that? Propofol has the advantage of causing no nausea and vomiting. It's actually an anti-nausea drug, and it has no residual respiratory depression. So that is a kind of anesthesia that's given intravenously, so we use what's called TIVA, or total intravenous anesthesia. That is terrific, but there's even more research. People said to themselves, gee, if these narcotics have good features because they work on a receptor in the body called the opioid receptor and relieve pain, maybe there are other receptors in the brain. Maybe there are other chemicals we can use that can relieve pain, maybe without some of the side effects of narcotics. And we found a variety of drugs which work as opioid-sparing analgesic agents. That is, they are pain relievers without some of the side effects of the narcotics. Now, we still use narcotics in our patients as the rescue agent if the other drugs don't work. But we found particularly in the brain 2 areas. One is the alpha-2 receptor in the brain. That's where clonidine, the drug clonidine, works. And the N-methyl-D-aspartate receptor, and that's where ketamine works. And what we found is if we stimulate those receptors with other drugs, we can decrease a patient's feeling of pain. So in our patients, we use drugs that affect the alpha-2 receptor and the N-methyl-D-aspartate receptor, and that includes melatonin, clonidine, gabapentin, dexmedetomidine, and a whole mix of drugs designed to decrease our patient's need for narcotics. And we heard, I forgot, did you have pain after your surgery?
I did, but I just wanted to, the abnormal one.
No, that's okay, but you had some pain.
I did.
And do you remember the numbers and how long and how many?
About 12.
You had a pain of 12. For how long?
Well, right after surgery, then, it kind of came on the pain until they moved me to my room. I had pain. Then once I kind of woke up in the afternoon, it was gone, and everything was hunky-dory after that.
So you had a pain of
We
12.
used a sharp samurai that day.
Right, but you had pain of 12 for the group, though. You had it for an hour or two or a couple of
Yeah,
hours?
just after surgery, just the stomach area.
Okay, but then for the next day, how was it?
No problem.
Okay, so that's terrible that you had pain for a couple of hours. If you're a nurse, you've seen other post-op patients?
Yeah.
A little bit more pain than an hour or two.
Yeah.
Right. So again, and pain for you after surgery?
Right.
And how much, how long? Or?
I'd say like a 9. And it was like we said, right after surgery when you're waking up.
Like when you're waking up.
Right, right. So that's terrible. But on the other hand, then the rest of the week?
No problem that way.
Yeah, and the rest of the week?
No problem.
Right.
No, we're running
So-
races or anything.
Exactly right. But if you take the average patient, that's a pretty remarkably positive result. And we would argue that it's because of our use of the opioid-sparing drugs, which includes the gabapentin. And a recent study confirms ours. We found that we could decrease our need for narcotics and anti-nausea agents by 90% by modifying our TIVA and adding in these opioid-sparing analgesic agents. It's an extremely exciting new area. Many people don't know about it or not using it yet. We're very excited about it. I've published a paper on it, and just recently in this month's issue is another nice article showing that the gabapentin helped decrease the use of narcotics in post-op patients. So really good question. And the reason